Hi, my name is Pushpika Jainiti. I'm going to talk about today respiratory failure. This is my case study. It's about Mrs. Rosie J. So, Mrs. Rosie J is 64 years old woman who came to Australia as a refugee from Cambodia. 3.5 weeks ago, Rosie had an appointment with her GP, advised about the worsening respiratory symptoms. The GP sent Rosie into the SPH emergency department and she was admitted into hospital for treatment. This is Rosie's isobar from the hospital. This is her identity. I talk about situation. This morning, Rosie was transferred back to the medical ward from ICU. She has a tracheostomy issue. Rosie was admitted with a diagnosis of CAP and respiratory failure, requiring an admission to ICU and ventilation 10 days. And that's her background. Also, assessment done and the recommendation. Just before I forget something in here, CNS says GCS score is 11, but if you see that because she lose GCS score, because she got 11, because she can't verbally tell that the person, place, and the time. But there are other way we can find out, like we can give a piece of paper and a pen, and we can ask questions. As long as she answered, we can document that, saying that she knows that she's alert and oriented. And for Rosie's case, I made a mind map, um, getting all the information cycle from the case study. So in this mind map mainly included etiology, pathophysiology, nursing management including assessment, interventions, and evolution. I'll explain you because it's a bit larger, so I have to zoom in and I'm not going through all the informations due to time consuming. So this is Miss Rosie Che. So I'll quickly tell her about the main point, the long history of tobacco use, 34 years, smoking 1.5 packets of cigarettes a day, breathless when she's walking on level ground, chronic productive cough has two or more exacerbation of breathing problem each year. She's diagnosed of respiratory failure. There are two types of respiratory failure. Type 1 is the blood oxygen is low, the carbon dioxide is normal or low. Type 2 respiratory failure is blood oxygen is low and the carbon dioxide is high. And this is the symptoms of the respiratory failure. Who is at the risk acute respiratory failure is the people who tobacco product use the tobacco, because if you see her, she's 34 years, she's been using 34 years, as well as she's smoking 1.5 cigarettes per day. So etiology. Etiology, community acquired pneumonia. When you say the community, that means it happened outside the hospital. That means it happened in the community, mainly caused by acute infection of lower respiratory tract. Chronic obstructive pulmonary disease is the number of long-term conditions is gradually developed over time. If you look at her history, it says exacerbation of breathing problem each year. That means she gradually increased her um, disease. Often results from risk factors such as smoking, and it's obvious things to see that 1.5 pack of cigarettes is a huge things to see. And also next one is pathophysiology. Pathophysiology, CAP, is an immune response from the body to commonly aspirated or inhaled microorganism. And pathophysiology of chronic obstructive pulmonary COPD. I just put a picture. I thought that would be easier to explain. You see, there's two types of COPD. The first one is emphysema. Second one is chronic bronchiolitis. So emphysema happen. This is it's the emphysema is disease of alveoli. When alveoli damage, it's hard to exchange exhale carbon dioxide of the lungs because it makes the less elastic, causing the difficulty. So, and if the lung airways become inflamed, mucus production, that's where chronic bronchiolitis happen. And I'll go through her nursing management here. So, if I talk about nursing management, the first one I talk about nursing assessment. The first one I talk about is head to toe assessment. Head-to-toe assessment is primary and the secondary head-to-toe assessment. When you say head-to-toe assessment, it's head-to-toe assessment. You have to go head-to-toe. Just finding any abnormalities, just document all the abnormalities. And the second one is focused respiratory assessment. You have to interview the patient with a history of respiratory disease, smoking, environmental exposure, and inspect her using accessory muscles, breathing shape, and the depth and rhythm, pattern, skin color, lips, face, hands, and everything. And they auscultate her lungs just to make sure she doesn't have any abnormal sounds. Next one going to be tracheostomy assessment. So just assess tracheostomy secretions from the tracheostomy side, presence of drainage, tracheostomy dressing notice, appearance, incisions, redness, swelling, and any discharge or odor. And I just put here vital signs just to make sure it's come with the head-to-toe assessment. And if you see here, this is normal range of vital signs. And the next one is a skin assessment, because if you see here, she got a history, she got a where is this small red pressure area to sacrum and heels. So, and then the skin assessment, so just to find out she got a history, what product she used, and her skin color, like appearance, any discoloration, breaking, everything has to be documented. And this is all the clinical manifestations I got from the findings: poor communications due to tracheostomy, chronic productive cough, fatigue, shortness of breath, increased work of breath, use of accessory muscles, and that's all the things in the here are found. And the finger clubbing common symptoms of respiratory disease. Actually, because if you see someone like that, that means the sign of respiratory disease. And the next one I'm going to quickly all the interventions I've done. The first one is um, avoiding pressure area, because as you can see, she got a pressure area. The next one going to be education on her tracheostomy, because the tracheostomy is something new to her. She need to understand how to look after when after the discharge, such as go for swimming, not for good for swimming until she fully covered her tracheostomy. So all the information's here. And during the hospital stay, the suctioning about the according to the hospital policy, just to make sure suctioning help her to get the air in. And the next one going to be referred to allied health professionals, including pharmacists, OT, psychology, speech pathology, and physiotherapy. They will help her with the daily living after her discharge. After pharmacological interventions prescribed by the doctor, it has to be doctor. Oxygen, analgesics, pain reliefs, antibiotics, bronchodilators, and inhalers, just to open her airways to help easy to breathe. And all the diagnostic interventions as per doctor's prescribed has to be doctor. And lung function tests, CT scan, blood gas analysis, blood tests, interim examinations, and ECG or EKG. These all tests help her to just to confirm her diagnosis, just to make sure what's the causes for this one, and so we can make the doctor can make the right care planning for that. After all, the evaluation, I talk about evaluation. So monitor small red pressure area to sacrum and heals until it get recovered. Diagnose interventions, follow up with the doctor, determine care planning, monitor vital signs including oxygen and the color with sputum, determine further infection. Refer to allied health professional to follow up appointment just to make sure. And assessing the pain, perform a pain assessment to assess pain if the analgesia has been useful. Education, assessing the understanding of tracheostomy care, care of the carer by performing the teach back method. Also in education in here, I put like a quitting smoking, because it's not easy to educate someone, navigate someone smoke 34 years old. So we have to give her resources, just make sure she's not getting her diagnosis worse. I went through everything very quickly because I didn't get much time, and all the information's here. And thank you so much for the opportunity.